Welcome everybody to care of patients with hematologic conditions. Some of this may sound repetitive, but I'm going to continue to go over the concepts on the slides. Just bear with me. The last one that we just did, 33, is going to repeat some of the same things. But anyway, so hematology again is the study of blood. So when blood is abnormal, everything in the body suffers because blood is responsible for oxygen delivery, immunity, clotting, and tissue healing. So many of these conditions look simple on paper, but they can become life-threatening very quickly, especially when the oxygen delivery or clotting is affected. So blood disorders affect systemic function because blood is the body's transport system. So priority concepts in this chapter, again, are perfusion and immunity that we've talked about. But again, perfusion is oxygen delivery to tissues, and immunity is the ability to fight infection. And so we have the related concepts like cellular regulation, bone marrow production issues, clotting, the platelets and the coagulation factor we talked about in the last chapter, gas exchange, the oxygen carrying capacity of that hemoglobin, infection, and pain. So if perfusion is impaired, the body becomes hypoxic. If immunity is impaired, infection can become deadly. So hematology is about whether the body can carry oxygen, clot appropriately, or fight infection. So now we're going to talk about anemia, and that is a reduction in either the number of red blood cells, amount of hemoglobin, or hematocrit. A clinical indicator occurs with many health problems. So anemia means the body's basically running low on oxygen fuel, and that's why anemic patients are tired, weak, dizzy, short of breath, maybe pale. So because anemia decreases the oxygen delivery and it leads to tissue hypoxia. Some common causes of anemia are dietary problems. They may not be getting enough iron, B12, or folate. Genetic disorders like sickle cell or thalassemia. Bone marrow disease like aplastic anemia or leukemia. Or it may be from blood loss like GI bleeds or trauma and surgery. So when you see anemia, the nurse's job is to ask, is the patient not making RBCs? Are they losing RBCs or destroying RBCs? And that's the best way to kind of organize your thinking. Symptoms of anemia are low oxygen. Other key symptoms: fatigue, weakness, pallor, shortness of breath, tachycardia, dizziness, and cold intolerance. Usually people with anemia are always cold and wearing extra layers. So why does tachycardia happen? So the heart compensates. It beats faster because it's trying to circulate what little oxygen is available. And tachycardia in anemia is compensation, not the primary problem. So if the patient becomes has chest pains or confused, anemia may be severe enough to threaten perfusion to the heart and to the brain. So there are different types of anemia. There's three major categories. Let's start with that. There's not enough production, meaning the bone marrow is not making enough RBCs, too much destruction in hemolysis, or maybe from blood loss. So we'll break it down into the common ones as iron deficiency, B12 deficiency, folate deficiency, aplastic anemia, the G6PD deficiency, autoimmune hemolytic anemia, anemia of chronic disease like kidney disease, or anemia related to blood loss. So different anemias have different causes, but they all lead to the same outcome: impaired oxygen. And going back to the kidneys, erythropoietin is a hormone that tells the bone marrow to produce red blood cells. So when patients have kidney disease, that hormone becomes sluggish and doesn't speak to the bone marrow. So in our kidney patients, we see anemia, and we have to give them a medication called Epogen, and you want to know that medication. We give them Epogen to stimulate their red blood cells. So iron deficiency anemia We'll have patients increase their oral intake of iron. Iron-rich foods include red meat, spinach, and beans. We also will encourage iron supplements. Because iron's required to build the hemoglobin, so without the iron, the RBCs become small and pale. Oral iron causes constipation and dark stools, so that's some teaching that we need to provide so that patients will understand and not freak out if they see their stool dark. Vitamin B12 deficiency anemia, increased intake of foods rich in B12. They may get B12 injections, oral preparations, nasal sprays, sublingual, just different ways you can take B12. Encourage foods rich in B12. If the cause is absorption problems, oral supplements may not work, so they may have to take it a different way. The folic acid deficiency anemia, prevent deficiency with diet rich in folic acid and vitamin B12. Folate is needed for DNA synthesis, so without it, the RBCs don't mature correctly. So encourage a folate-rich diet, often paired with B12 support usually. Iron builds hemoglobin, B12 and folate build healthy cell development. Aplastic anemia, this is serious because it's bone marrow failure. Usually we'll see low red blood cells, low white blood cells, low platelets, so patients will present with fatigue, infection risk because of the low WBCs, and of course bleeding risk with low platelets. It's treated by blood transfusions and immunosuppressive therapy and bone marrow stimulants. The G6PD deficiency, this is a genetic disorder where the RBCs break down when exposed to certain triggers, and those triggers can include infections and certain medications. The treatment for that is discontinue the trigger, hydration, supportive care, and transfusions if it's severe enough. G6PD is not treated with the medication. It's treated by avoiding the trigger. Autoimmune hemolytic anemia. This is when the immune system attacks the RBCs. The treatments include steroids and possibly a splenectomy because the spleen destroys the RBCs. Anemia of chronic disease. This is a common in chronic inflammation, kidney disease, cancer, things like that. The main idea is the body can't use the iron effectively even if the iron is present. Treatment for that is underlying cause. The erythropoiesis stimulating agents like EPO, like I just talked about with the kidney. Again, you need to know that med. Blood loss anemia, fix the bleeding first, and that is the root problem. So if it's a bleeding issue, we want to fix the bleeding first, of course. We will treat with transfusions if severe enough and iron replacements. So you don't treat anemia correctly unless you treat the cause, basically. Themia vera. This is basically the opposite of anemia. Polycythemia vera is cancer of the RBCs where the body produces too many blood cells. Too many RBCs, too many WBCs, too many platelets. So the blood becomes thick like sludge, and thick blood increases the risk, of course, stroke, MI, DVT, PE, things like that. Polycythemia vera is dangerous because the blood's too thick to flow smoothly, so clots can form easily. Some cues on assessment with polycythemia vera. Facial skin is flushed and warm, and that's due to the more red blood cells causes more blood volume and congestion. The intense itching is a classic sign because of the histamine release and increased blood cell activity. Hypertension may be present with thicker blood. That increases that vascular resistance and causes the blood pressure to increase. Poor gas exchange may sound confusing because you see more red blood cells, and you would think that would mean better oxygen perfusion, but the blood's so thick it can't circulate effectively. So keep this in mind. Shortness of breath, ABC still a priority. You may still see shortness of breath with this. Bleeding problems. Even though platelets are high, they may be dysfunctional. So polycythemia causes both clotting risk and bleeding risk. This is fatal if it goes untreated because clots can form anywhere. Therapeutic phlebotomy may be used. This is really the main treatment they use to remove the blood to reduce the thickness. Apheresis is a similar concept, removing specific blood components. Hydration is essential because it dilutes the blood volume and decreases clot risk. Promote venous return, like walking, leg exercises, and avoid prolonged sitting. And then drug therapy would be anticoagulants and other medications depending on the severity. In polycythemia vera, hydration is a safety intervention. Multiple myeloma is a cancer of mature B lymphocytes, specifically plasma cells. Plasma cells normally make antibodies. In multiple myeloma, they make abnormal proteins that damage organs. The MGUS and smoldering myeloma. MGUS is abnormal protein, but no major symptoms yet. Smoldering myeloma is early stage and still often asymptomatic. Symptoms include fatigue, bone pain, easy bruising, recurrent infection, and kidney problems. And the bone pain occurs because cancer cells live in bone marrow and weaken the bone structure. Abnormal proteins clog the kidneys. Multiple myeloma is dangerous because it destroys bone marrow function and produces abnormal proteins that damage kidneys. Treatment is geared toward alleviating symptoms and decreased risk for end organ damage. Thrombocytopenia. This is about platelet destruction disorders. Thrombocytopenia is low platelets. The purpura is bruising and petechiae. And again, you need to know that word. ITP, immune thrombocytopenic purpura. This is where platelets are destroyed by the immune system. Symptoms are easy bruising, petechiae, and purpura. Treatment is corticosteroids, drug therapy, and splenectomy. And then TTP, this is more severe and life-threatening. Signs are the purpura, pallor, weakness, fever, and RBCs in urine. Treatment is plasma exchange. The HIT is a dangerous immune reaction to heparin. So symptoms include pain, redness, and swelling in the extremity. Be aware of that. Paradoxal clotting risk. The treatment is to stop the heparin immediately and use alternative coagulants. And then HIT is low platelets but high clot risk. DIC, this is one of the most dangerous clotting emergencies you'll see. DIC, widespread clotting throughout the body, which uses up clotting factors, so patients will end up with microclots everywhere and then severe bleeding everywhere. And it happens because it's by what it's triggered by: sepsis, trauma, sometimes OB emergencies, or cancer. And so what you'll see clinically is bleeding from IV sites, bruising, organ failure, and shock. This is a very serious thing. The patient is clotting and bleeding at the same time. So the treatment is treating the underlying cause, and DIC is a medical emergency because the patient is consuming all clotting factors. Transfusion types, the RBC transfusions used to increase oxygen carrying capacity after a trauma, surgery, or severe anemia. Platelet transfusions, used when the platelets are low or bleeding risk is high. Plasma transfusions, used to replace clotting factors or blood volume. Granulocyte transfusions are rare, but for severe neutropenia. Massive transfusion protocol, This is used when the hemorrhage is severe and the H&H is dangerously low. We don't just transfuse whole blood. Modern transfusion therapy is component-based now. So transfusion therapy, some pre-transfusion responsibilities. You want to make sure you're reviewing the agency policy. You want to verify the prescription with another RN. It has to be 2 RNs to verify blood. Test donor recipient's blood for compatibility. So type and cross should have been obtained before it starts, of course. Use 2 patient identifiers, check expiration, inspect the blood bag. And so what you're looking for in that blood bag is cloudiness, bubbles, discoloration, things like that. The nurse is actually the final safety check before incompatible blood enters the patient. And then, of course, there's the protocol as you begin the transfusion, things that you need to watch for those first 15 to 30 minutes, but that will be per facility. Okay, this slide's talking about the transfusion responsibilities. So you're going to be using filtered tubing that will remove clots and debris. Only hang normal saline. Never hang dextrose or lactated ringers because it can cause hemolysis or clotting. So only normal saline with blood. Stay with the patient the first 15 to 30 minutes because if a reaction happens, it's going to happen early. Make sure you're infusing at the correct rate to prevent fluid overload, especially in heart failure or renal patients like mine. Vital signs are your early warning system, so we're going to be watching for chills, back pain, fever, shortness of breath, so that transfusion can be stopped. Sometimes patients are pre-medicated with Benadryl before transfusions, but the doctor will order that. So acute transfusion reactions occur within 24 hours. Delayed reactions can occur up to 30 days. Types include febrile reaction, hemolytic reaction, allergic reaction, and bacterial reaction. The most dangerous is the hemolytic reaction. Back pain, fever, chills, hypotension is a hemolytic reaction until proven otherwise. Autologous blood transfusions is when a patient donates their own blood in advance. The benefits of it eliminates compatibility issues, it decreases the risk of blood-borne infections, and sometimes this is done for like planned surgeries, joint replacements, major orthopedic surgeries. It's the safest blood because it belongs to the patient. Okay, so now let's apply what we've learned. Hematology questions are usually about priority nursing interventions and safety. So let's do some questions, guys. The nurse is caring for an older client with a history of diverticular disease and pernicious anemia. What is the priority nursing intervention? So the answer is A, and some of you may have selected something different. The client will have difficulty absorbing vitamin B12 because of diverticular disease. So this took some thought and may have developed paresthesia in the feet, increasing the risk for falls. Anemia may also increase the client's symptom of weakness, thereby increasing the fall risk. Preventing falls is a priority intervention in the care of older adults. All other interventions can take place after safety has been ensured. So always think safety first, especially in older adults. That's important to know. Okay, a client with polycythemia vera is admitted with shortness of breath, hypertension, and loss of pulses in the right foot. Which nursing intervention is the priority? So the answer is A. Hydration status is most important because hydration affects the blood thickness, the clot risk, and perfusion to the extremities. So if we can reduce the viscosity, then we can reduce the clot progression. Hydration is the most immediate nursing intervention because it directly improves circulation. So the answer is A.